So, Dr. Shore, we've had a fairly extensive overview using the prostate cancer disease continuum slide in terms of what is currently available in the castration-resistant prostate cancer space. We've talked about the use of Sapulous LT, we've talked about the use of docetaxel, and then when patients fail docetaxel therapy, we've discussed cabazitaxel or Jevtana, abiraterone or Zytiga, enzalutamide or Xtandi. What other new therapies that are not yet FDA approved but are currently in clinical trial can you expound on for us?
We've had a great discussion of the remarkable achievements in the disease continuum of prostate cancer, starting in 2004, the approval of docetaxel, 2010, Sapulous LT, and then 2011, cabazitaxel, then abiraterone, and then most recently enzalutamide. Really remarkable in less than 10 years, all of these new therapeutics which have distinct mechanisms of action. And one would hope that they could be additive in their impact on prevention of disease progression, but more importantly, prolongation of life, maintaining survival, and maintaining quality of life. So your question, what else is out there? It's almost it's like a greedy question, isn't it? We've had so many great improvements, and we really stand quite alone in the field of advanced prostate cancer. It shouldn't be lost on our audience that many other advanced malignant disease states are not enjoying the success that we have, and we certainly hope that they will. But we should be very proud and satisfied by the advances that we've made, both from a bench science to clinical science. So there are even more and newer therapies that are on the way. Certainly we've had some great results in phase 3 trials for the castrate-resistant prostate cancer patient. In no particular order, let's look at a new isotope that has been trialed with great success, and it's called radium-223. Historically, we've had the approval of other isotopes for the amelioration of pain for men with CRPC and bone metastases. And these infusions of isotopes have been successful in alleviating pain, but have never shown an improvement in overall survival. The Alsimca trial, which was completed over a year ago, which was a multinational study and a phase 3 trial, not only showed amelioration of pain and a reduction in the incidence of skeletal-related events, but really most importantly, showed improvement in overall survival. And we see a median overall survival of approaching nearly 4 months. And this has now been presented at the European Society of Medical Oncology, the American Society of Clinical Oncology, and it'll also be presented at the AUA. So it's very exciting. It's at phase 3 that's been completed. At some point, we're hopeful that in 2013 there will be an application filed with the Food and Drug Administration. And this is a different type of an isotope. It's called an alpha isotope particle as opposed to beta gamma. In short, it's a very large particle. Why is that important? It's important because it has a shallow depth of penetration to the cortical bone where the metastases are. This is important because it doesn't penetrate deep into the bone marrow and doesn't cause anywhere near the levels of myelosuppression we've seen with traditionally approved isotopes known as strontium and samarium. So by avoiding myelosuppression, one then has the ability later on to potentially offer cytotoxic chemotherapies that are approved, like docetaxel and cabazitaxel. So it gives us a whole nother mechanism of action for our patients with bone metastases specific CRPC. Very, very exciting. It theoretically is a completely different mechanism of action from immunotherapy and targeted oral agents as well as cytotoxic chemotherapy. And for the treating clinician, the safety profile is quite good. the adverse event profile is quite minimal. Very well tolerated by patients. So I'm very excited about that for 2013, and hopefully that will be approved by the FDA and then eventually EMA as well. In addition to the radium-223, there is also other therapies that are completing phase 3 trials now in CRPC. There are 2 other immunotherapies that are being trialed. One called ipilimumab, which is a CTLA-4 antibody blocker. Essentially what this does is it releases the brake, or what we call the checkpoint, on immunotherapy. So it allows the T cells to be more aggressive by taking the brake off of them that we have naturally in the immune system. There are 2 phase 3 trials that are ongoing and the results are pending. This immunotherapeutic has a different mechanism of action from the already approved Sipuleucel-T. So one can postulate maybe the 2 of these could be additive together and further stimulate the immune system to fight the cancer cells. And the cancer cells presumably have become tolerogenic, or we've developed tolerance to these proteins on the cancer cells. And immunotherapy has always been the holy grail of therapeutics to help us better fight cancer in a way that's well tolerated. There's another phase 3 trial in immunotherapy known as PROSTVAC, and this is looking at PSA and a series of other co-stimulatory molecules given subcutaneously rather than intravenously. Sipuleucel-T and ipilimumab are given intravenously. PROSTVAC's given subcutaneously. In a phase 2 trial, the survival benefit was greater than 8 months. Smaller numbers, and that's why we're doing now a phase 3 trial. Like Sipuleucel-T, it was very well tolerated. So we have these 2 other forms of immunotherapy which have different mechanisms of action to stimulate the immune system, fight the cancer cells for patients with CRPC. So I'm extremely sanguine about those potential trials. I'm also, as I said, very excited to see the application for radium-223 in front of the FDA. There's also other things too. Historically, we've not been able to find a combination therapy with the approved chemotherapy docetaxel. There have been many trials called couplet trials where we add something to the docetaxel to try to improve its efficacy. And none have worked. But in a phase 2 study, we looked at a molecule called custirsen. And it has shown in a phase 2 study, given in combination with docetaxel, to improve progression, delay progression, I should say, delay progression-free survival, very well tolerated. And now we've just completed a phase 3 trial, and we're awaiting the data not just on progression-free survival, but more importantly, overall survival. So I'm very enthusiastic about that. There are other molecules. There's an oral agent known as tasquinimod. This is an agent that's given orally, which in some ways is a little more convenient for patients and perhaps even more convenient for monitoring. In phase 2 studies, it was exceptionally well tolerated. It's in the family of tyrosine kinase inhibitors. But the phase 3 trial for patients with metastatic castrate-resistant prostate cancer is just nearly completing accrual. Meaning that we've filled in all the number of patients and subjects to complete the trial specifications. And I'm enthusiastic about it because of its tolerability profile, and we're certainly hopeful that we'll see results in the next couple of years in terms of survival. Again, as I said earlier, all of these additional phase 3 pending trials have different mechanisms of action from those products we've mentioned that have received approval. And just to be complete, and one really can't be complete because we have more phase 1 and phase 2s that time doesn't allow me to tell you about, but we have additional androgen receptor signaling inhibitors that are being trialed that may be competitive in terms of efficacy and or tolerability with the most recently approved androgen receptor signaling therapy called enzalutamide. So that's exciting. We also have additional androgen biosynthesis inhibitors that are being trialed, one known as orteronel or TAX700. That's being trialed right now in phase 3, which is to some degree similar in its mechanism of action to abiraterone, but there's always the potential that we might see additional applications. So it really is not an understatement to say we have this exuberant embarrassment of riches for our patients with advanced prostate cancer.